Not unless we have somebody that. All right. So for those of you who are live with us, we're going to get started here in just a couple minutes. Okay. Okay. All right, so we're going to go ahead and get started. So, welcome to everybody. My name is Amy Smith. I am the Bariatric Program Manager here at Northeast Georgia Medical Center here in Gainesville, Georgia. So, glad that you were able to join us here today. So, we're going to go ahead and get started with the class. What I'm going to talk to you guys today about is who is a good candidate for bariatric or weight loss surgery. I'm going to talk to you about the benefits and risks of each of the procedures that we have here. And we're going to talk about the dietary lifestyle changes that are necessary to be successful with these types of surgeries. And then towards the end, then we'll talk about what are the next steps to proceed in the program. One of the things I want to make sure that you're aware of is on the right-hand side of your screen, you should be able to type in questions. So you can ask. I can type this morning. You can ask questions here. Okay. All right. So that way, as I'm speaking, if a thought comes to your mind, you've got a question that you really want to get answered today, I want to make sure that you have that opportunity. So just be sure to type some questions over to the right-hand side there of the screen, and I'll be happy to answer those questions as we go through this morning, okay? Well, first of all, we're going to talk about, let me just get us so that my clicker works here. There we go. So here's our objectives today. We're going to define obesity. We're going to talk about the various treatment options of obesity. We're going to talk again about the lifestyle changes that are necessary. At the end of this video, I actually have 3 very short videos to introduce you to our surgeons. We have 3 surgeons here in our program. And then we're going to talk about what the next steps are, okay? So at the end, let me go ahead and type this in for you. At the end of this, make sure I spell her name right this time. Okay, this is the email address I'm going to give to you guys. You can have that ready at the end. If you want to move forward at the end, regardless of the option that you choose, I want you to have a contact information there so that you can reach out. And then the number here to our program, I'm going to put up there also. There you go. All right, so we're going to jump right in here and let's talk about the definition of obesity. Okay, obesity is defined as a BMI of 30. BMI is just a fancy, word for body mass index, and what it is it's a calculation, a formula. And what we do is we take your height and we take your weight and we put it into a formula, and what it tells us is the severity of obesity, where you fall on that spectrum. What we know about obesity is that it's chronic, it's relapsing, it's multifactorial, meaning that there's several things that lead to obesity. It's not just one thing, it's multiple things that lead to obesity. There's a psychological component, there's immunity, there's definitely genetics, there's environmental factors, there's endocrine issues, metabolism certainly plays a role. And believe it or not, there's many medical conditions that can lead to obesity as well. Something else that can lead to obesity is hormones. And so we do have 2 types of hormones in our body. One is called ghrelin, and that's what we call the hunger hormone. When you have a large amount of ghrelin that is produced, it gives you an over sensation of hunger. It makes you want to eat more. And then we have another balancing hormone that's called leptin. Leptin is what we call the satiety satiety hormone, or the hormone that tells us that we're content, we're satisfied, we've had enough. And what we know is that in our obese population, there can be a mismatch or an under production of these 2 hormones in our body. That's going to be important for you to know as we talk a little bit about the anatomy of weight loss surgery and how they work. Okay, so in 2013, the American Medical Association actually recognized obesity as an official medical disease. That's important because what it allowed is for us to pressure insurance companies to treat obesity as the disease that it is. So as if someone had high blood pressure, diabetes, there's a treatment for those issues. And by defining it as an official disease, it means that we have to provide treatment options for obesity. The other thing it did for us is it also helped us to treat type 2 diabetes. In particular, the gastric bypass is the gold standard for the treatment of type 2 diabetes because we can put diabetes into remission anywhere from 80 to 90% of the time, specifically with the gastric bypass. So it definitely has helped us to impact the number of patients with type 2 diabetes. So there's a few treatment options in our program. I'm going to go over those here quickly just so that you're aware of all the treatment options. Here in our program, we do have a bariatric dietitian who specializes in counseling patients with obesity in order to gain weight loss. Many times she's able to look at a patient's daily habits and she's able to tweak what their dietary habits are to gain weight loss. So if somebody's never sat down with a dietitian and learned about their body's needs and about what foods they could be eating and substituting with to gain weight loss, that could be a very good start for patients. Now, here in our program, we have reduced rates for nutritional visits. The first visit is $60. After visits are about $39 for follow-up visits. Outside of our system, you could pay anywhere from $80 to $120 per visit with a dietitian. So for some patients, that may be a good option. We also have bariatricians, which are medical weight loss doctors. We have several of those here in our program. And so a bariatrician can put a patient on a medically supervised diet, which may involve things like meal replacements, appetite suppressant medication. So if you've never tried that route, that may be a good solution for you. We have something called the intragastric balloon, which is a non-surgical approach, which I'm going to go into detail here further in the next few slides. And then, of course, we've got metabolic and bariatric surgery, also known as weight loss surgery. And I'm going to definitely go into those in great detail here in just a couple of minutes. One thing I want to share with you is the impact of obesity on the body. This slide is a great slide. It actually does show everything that's going on in the body of our patients. And so some patients begin with some minor aches like joint pain, back pain, things like that. But as obesity continues down the road, and it worsens, our patients can develop other medical conditions related to obesity. There's actually some cancers that are associated with obesity, but in the psychosocial area there, we do see patients that struggle with anxiety, depression, body image issues. In the lungs, we have an increased risk of asthma, sleep apnea. In the GI tract, we have an increased risk of gallstones, and non-alcoholic fatty liver. In the renal or the kidney area, mostly related to type 2 diabetes, we can have patients that begin to suffer with kidney failure. In the heart, we do struggle with patients who have high blood pressure, high cholesterol, coronary artery disease related to obesity. Now, in the endocrine system, we have patients who develop what we call insulin resistance that later leads to diabetes. There's also polycystic ovarian syndrome, which can lead to infertility. So lots of things can come along with obesity, but what we know is that if we treat the root cause, which is the obesity, then we can get anywhere from 40 to 60 other chronic health conditions under control. So I share this slide not only in this course as people are beginning to explore their options for the treatment of obesity, but I'll also share this slide right before surgery as people begin to question their decision, start to get anxious or nervous about their surgery, because we need a reminder as to why. And sometimes patients will say things like, isn't this a drastic, choice with weight loss surgery? Well, the reality of that is that weight loss surgery is actually safer than having your gallbladder removed, and yet the benefits are tremendous. So that's important to know. And I'll show you some statistics here later on as we talk. Now, this slide here talks about the severity of obesity And it shows us, how obesity can progress and get worse. So as we started the discussion, we defined obesity as a BMI of 30. So here's our BMI of 30 here in the category of obese. For patients that are interested in weight loss surgery, typically insurance companies, the policies that do provide benefits for bariatrics, the coverage typically begins at 35. A BMI of 35 to 39.9 is in that category of obese. And typically insurance companies, if you're in that category, will require a health condition related to obesity. But one thing I want to show you is if we go up to the next level of obesity on the spectrum, we come to this word that's called morbidly obese. And that's a patient who has a BMI calculated with their height and weight of 40 or greater. And if someone hits a BMI of 40 or greater, many insurance companies that cover bariatrics will not require a health condition, because we know it's not a matter of if, but rather a matter of time when they begin to develop other health conditions. And so typically they don't necessarily require a health problem associated with obesity to cover weight loss surgery. One thing I do want to point out is in this category, the word morbid is used. And simply put, this word means that the weight, the obesity for that patient is going to impact their lifespan. So the morbidity of that patient. And so that can be very eye-opening for patients. I actually had a friend many years ago who went to a bariatric surgeon for a consult. She called me afterwards and she said, "You won't believe what he put on my chart." I said, "Okay, well, what did he say?" She said, "Well, I was morbidly obese." Well, technically on the spectrum of obesity, that's correct if you hit a BMI of 40 or greater, because we know that it can decrease the patient's lifespan. Okay, so let's talk a little bit about, let's see what I have on here. I've already spoken about this. This just kind of reminds you on the pricing for the nutritional counseling. Many insurance companies do not cover nutritional counseling in regards to obesity. However, they may cover if you have things like diabetes, because a lot of people will cover if you have type 2 diabetes. So just be aware of that. We do cash pay here in our program because of that. One thing I do want to point out is for our patients that choose to have weight loss surgery at Northeast Georgia Medical Center, we do offer this nutritional counseling for free forever for all of our patients. We do that on purpose because it's an added benefit, and we do want to set our patients up for success. So our patients can have as many nutritional appointments as they need. I've already spoken about the bariatricians or the medical weight loss option, but let's talk a little more detail about the intragastric balloon, which is a non-surgical procedure for weight loss. One thing to know about the intragastric balloon is that it is a cash pay only procedure. Many insurance companies do not pay. However, I have recently heard of one or two companies that have begun to add this to their benefits. Now, an intragastric balloon will run someone around $6,800, so that's something to be aware of. But if you are interested in this, I would check the insurance benefits just in case your insurance company has added this. So while $6,800 may be expensive for a non-surgical procedure, it may very well be a good option for some patients who are not quite ready to commit to a weight loss surgery. The commitment for this is 6 months with the balloon in place, 6 months for counseling with nutritionists afterwards to maintain that weight loss. A patient would be a good candidate for this if they fell into that BMI category of 30 to 40. If you do not know what your BMI is, you can go to your smartphone and you can download a free app. Just put in BMI calculator, and you will just simply add in your height and your weight, and you will be able to find out what your BMI is so that you know what you're a candidate for. The procedure for an intragastric balloon is very quick. It's 30 minutes long. It does require sedation, and then the patient will have an endoscope or an endoscopy where the scope goes down through the mouth into the stomach. The surgeon will look around in the stomach, and then he will actually place the balloon in the stomach and blow it up with saline. The balloon that we use here in our program is called Orbera, and I'm going to show you a video of how this is done with Orbera. Typical weight loss with Orbera can be anywhere from 30 to 50 pounds. And so again, it's limited to a BMI of 30 to 40. So if that is you, this may be a good candidate. So this is Orbera. Let me see if I can get our video here to play. There's no sound for this video, but you see the endoscope going down, the balloon being placed into the stomach, and then it's blown up with saline. This balloon holds about 500 cc's of saline. It weighs about 2 pounds. It occupies space in the stomach so that the patient feels fuller and is able to feel comfortable and satisfied off of a smaller amount of food. After 6 months, the balloon is then deflated through endoscopy and it's removed. And then the patient attempts to maintain their weight loss by working with a dietitian. So again, it's a 12-month commitment, 6 months with the balloon in, 6 months with the balloon out. Some things to think about with the intragastric balloon is that our patients are at an increased risk for developing gastric ulcers simply because there is a foreign object in the stomach. And so we do use anti-ulcer medications to protect the stomach during that time. Some patients do complain of nausea simply because of the sensation of that balloon being in their stomach during the first 2 to 3 days after the procedure. So we do use anti-nausea medication to keep those symptoms under control. So monthly dietitian visits are required. You do get a behavioral coach, and there is a support group for patients that have an intragastric balloon. Again, the average weight loss with this procedure is 25%, which for most patients equals 30 to 50 pounds. So I've covered now nutritional, I've covered the bariatrician or medical weight loss, and now I've talked about the intragastric balloon, which is the non-surgical procedure for weight loss. So at this point, I want to pause for questions. Remind you that on the right-hand side of your screen, you can type in any questions that you may have up to this point, and I'm happy to answer those. While I'm waiting on questions, we're going to move on. So we've talked about the potential complications with the intragastric balloon of nausea and vomiting, which we control with medication. Now, there is a potential risk for the balloon to fail and migrate. And simply put, what that means is if the balloon were to pop, like a breast implant perhaps, that balloon could work its way further down the GI tract and need to be removed by the surgeon. There is a chance the patient might develop intolerance, meaning that the patient would not be able to really get over that nausea and vomiting, and so the balloon might need to be removed. Now we're going to move into the weight loss surgery section of this lecture. One thing I'd like to share with you is that here at Northeast Georgia Medical Center in Gainesville, we are a National Center of Excellence for Bariatrics. Our accreditation is through MBS AQIP, and what that means is that every 3 years we go through a very stringent survey. Every year we're evaluated, and we do have to enter data on every case that we perform here at our center because we are monitored very closely for our quality outcomes and patient satisfaction. Because we are a center of excellence, this gives us, again, the national recognition, but it does mean that we have to meet very stringent criteria. One of that criteria is that we do not place our patients just anywhere in the hospital just because there's an open bed. Our patients are required to go to a specific bariatric unit. We actually have 2 units here at the Gainesville campus. One is located here in the North Patient Tower, and I call it the penthouse, but it's up here on the 6th floor. That's our bariatric unit where our patients spend the night for our inpatient procedures. Typically, the hospital stay is just overnight. After I'm teaching this class today, I will go and I will round on our patients in the hospital, do their discharge education, and get them home. So our patients who spend the night in the hospital typically go home around lunchtime or so. So it's a very short hospitalization. As long as their nausea, pain is controlled, they're able to urinate on their own, and they're able to walk well. Then they're able to go home the next day. Now, we do have a select group of patients, perhaps our younger, more healthier, lower BMI weighted patients that might be a good candidate for outpatient bariatric surgery. Those procedures are performed in our North Patient Tower. Our patients recover here on the second floor, and those patients typically go home on average about 7.5 hours after surgery. Those patients tend to do very well. So those patients will walk about an hour and a half after surgery and go home just a few short hours after surgery and are able to go home and recover and sleep in their own bed that night. So some of our patients are a candidate for outpatient bariatric, and that would include the sleeve gastrectomy and the gastric bypass. So some things to know about weight loss surgery, also known as bariatric and metabolic surgery, simply because not everybody chooses to have these surgeries simply for weight loss. Many patients choose to have it for metabolic health conditions, mostly related to acid reflux or heartburn or type 2 diabetes. There is a select group of patients that have reflux or heartburn that are able to get their procedure covered under medical insurance, even if they don't have bariatric benefits, simply because we're treating a medical condition. So that is something to consider. Now, for those patients that do have bariatric benefits, you can call the number on the back of your card, or somebody here in our program's happy to check your insurance benefits as well. But you can ask if you have bariatric or weight loss surgery benefits. If you do, sometimes they will come back, and some people will think maybe they don't have coverage because they'll come back with saying, well, if it's medically necessary. Okay, we don't do procedures for plastic surgery. All of our procedures are medically necessary because we're treating the disease of obesity and we're treating many other health conditions. So if you call your insurance company, they tell you that they cover, but if it's medically necessary, that's what that means, okay? Now, some things that you need to know, again, just as a review on the BMI, most insurance companies require a BMI of 35 to 39.9 with these type of health conditions: sleep apnea, high blood pressure, high cholesterol, heart disease, acid reflux or heartburn, type 2 diabetes. Now, if you have a condition other than this, then it may be considered. So if you have something like polycystic ovarian syndrome, non-alcoholic fatty liver, there's many other health conditions. So if you do not have one of these conditions I have labeled here, that does not mean that you're not a good candidate. These just happen to be the most common. Down below, again, what I said about the BMIs, if you meet a BMI of 40 or greater, for some insurance companies, it's regardless of if you have a health condition related to obesity. So I would continue to get more information. If you do not have any health conditions, there may be a test that you can do in your house, which is called a home sleep study. Some patients actually suffer with sleep apnea and they have no idea because it's a very mild sleep apnea. But if you have no other health conditions and you have this test and you get diagnosed with a mild case of sleep apnea, that could be what qualifies you through your insurance for surgery. So I just want you to be aware of that. Now, for my patients that do not have health insurance with benefits, I want to speak to you for a minute. For patients who have state health benefits, or state health employees, that usually falls in the category of someone who is a teacher or a postal worker, school bus driver, policeman, firefighter. We sometimes have patients who have state health benefits. Unfortunately, in the state of Georgia, our state has decided not to cover bariatrics in their health insurance, and that's something that we have actually been fighting for several years with legislature down at in Atlanta. So just be aware of that. We do have some people that call and their employer has excluded that benefit. So it's called an employer exclusion. So in other words, somebody can have Blue Cross Blue Shield or Aetna, which we take, and we do have a center of excellence through them. But if their employer decided to exclude bariatric benefits to make the premium cheaper for others, then they may not have bariatric coverage. So I want to speak to those patients right now. Some patients choose to be self-pay despite not having insurance benefits because their obesity is impacting their quality of life, and they are finding themselves in a situation to where they are developing chronic health conditions related to obesity. So I've had several patients through the years in that situation. The benefit to being self-pay is that we can perform surgery on lower BMI patients. That doesn't mean that they're not medically necessary, but it does mean that the surgeon on select patients may choose, for example, to do a patient lower than a BMI of 35, perhaps around 33, with somebody who has type 2 diabetes, because medically we know it would benefit, and the benefit would be better than the risk, because we could put their type 2 diabetes into remission 80 to 90% of the time. Another thing that's a benefit of being a self-pay is that a patient doesn't have extended wait times. Some insurance companies require that the patient undergo a 3 to 6 month supervised diet. Without having to be adherent to insurance regulations, the patient wouldn't necessarily have to do that and could get to surgery sooner, in weeks instead of months. So some things to think about: there is financing for weight loss surgery or bariatrics for those that do not have insurance benefits. Two of the companies that we work with, one is called Prosper and the other is Health Credit Services. Those companies, you can go online and you can enter your information and you can find out if you would be eligible for a medical loan through them right away without even having to speak to somebody. Now they do go based on credit score, so that may be something to consider there. Having said that, I have had patients that have taken out medical loans. I've had patients that have taken money out of their 401k. I have had patients that have started GoFundMe accounts to get the surgery because they needed to have surgery to save their life or to get their life back. So just know that it can be done. Patients have been creative, and it doesn't necessarily mean that you can't have surgery just because you don't have insurance benefits. Some other things to think about is that if you have the opportunity to switch insurance companies, if you do not have insurance benefits, usually in the fall is open enrollment around September or October. So I would advise that you investigate, but verify that there's bariatric benefits before switching. So just know that that is also an option. Now, when it comes to the cost of out-of-pocket paying for these types of surgeries, you may be asking yourself, how much does it cost? A sleeve gastrectomy here in our program costs $17,800, and a gastric bypass is around $20,000. Now, while that is a lot of money and it is expensive for somebody who's trying to get their quality of life back and to get their health conditions under control, many patients choose to move forward with a medical loan or some of those other options I just discussed. I had one patient that told me, Amy, people take out a loan all day long for a house and a car. I'm taking out a loan for my life. And that's exactly what he did, and he got his life back. So everyone's situation is a little bit different, and if you have any questions about that, we're happy to answer those. So again, to the right-hand side of your screen, if you have any questions up to this point, don't be afraid to enter those in, and I'll get those answered before the end of this talk. Now, because we are a center of excellence, we are required to share what our procedure numbers were for the last calendar year. In 2019, we performed 88 sleeve gastrectomies, 105 Roux-en-Y gastric bypass, and about 55 revisional type procedures as well. So let's move on and speak specifically to the weight loss procedures. First, we're going to start with talking about the vertical sleeve gastrectomy, which some people call the sleeve for short. Now, on the left-hand side of your screen is normal anatomy. So I'm going to talk to you for a minute about what our normal anatomy is, so that when I go forward and speak about the sleeve or the gastric bypass, it will make more sense when I explain the anatomy and how these procedures are performed. So on the left-hand side of your screen here, what you see is the esophagus, and then you see the stomach. Here at the base of the stomach, on the inside is a valve called the pylorus. The pylorus is the outlet of the stomach, and that valve opens to let food out to digest, and it closes to let food churn and get broken down by gastric acid. So it opens and closes at the base of the stomach. After the pylorus is the first part of the small intestines called the duodenum. And then further downstream, we have the second part of the small intestine called the jejunum. So that's our natural, normal anatomy. On the right-hand side of the screen here, you see a patient that has had the sleeve gastrectomy. So their stomach has been altered. The sleeve gastrectomy was actually invented many years ago, over 20 years ago at this point, by a bariatric surgeon that had super morbidly obese patients that were so unhealthy that he was concerned that they would not be able to withstand the longer procedure and more complex procedure of the gastric bypass. And so to treat that obesity, what he decided to do was to do the first stage of that procedure, which was reducing the size of the stomach, with the intent of, after that patient gained a significant amount of weight loss and reduced their risk of surgery, he would go back and he would do the second part of the second part of the surgery, which was the rerouting of the intestines below. What the surgeon found is that the patient actually had such great success with weight loss that the majority of his patients did not have to go back for the second portion of that procedure. Hence, the sleeve gastrectomy was created. So what the surgeon does in this procedure is he simply reduces the size of the stomach by about 80%. He uses a stapler that cuts and seals at the same time in the operation. So here, not sure if you can see it at home on your screen, but there's actually a staple line that goes up the side here of the stomach. So the surgeon starts at the bottom and he cuts and seals, laying down 3 rows of staples on either side. So if you've ever heard of something called the food saver, okay, it used to be something that people would put food in a plastic bag, they'd put it in the machine and it would seal and cut at the same time. Similar technology, only these staples do remain in place. So that section of the stomach, which is called the greater curvature of the stomach, is actually permanently removed from the body, and the patient is left then with a reduced size stomach with 3 rows of staples down the side that remain in forever. The surgeon then hand sews across the entire staple line there, and then he squirts something called Tisiol, which is a tissue sealant, over that incision. And so 3 layers of leak protection. So I speak about a leak because a leak is a complication that we worry about in our procedures, and that's why we do everything we can to prevent them. So 3 layers of leak protection, staple, stitches or suture, and then tissue sealant called Tisiol. After this part of the procedure is performed, the surgeon floods the abdomen with saline and he injects air through a tube in the patient's mouth where they're asleep and unaware, and he's looking for air bubbles, almost like checking a tire for a leak. Okay? After he performs that and he ensures that there is no leak, then he's able to leave the operating room. So this is in essence the way that a sleeve gastrectomy is performed. One thing to note, that by removing this greater curvature of the stomach with a sleeve gastrectomy, this is actually the area where the hunger hormone ghrelin is produced. So it's very common, very normal for patients after the sleeve gastrectomy to not feel a sensation of hunger. Okay. Now, we call that the honeymoon stage, though, because those little cells will begin to regenerate and will begin to reproduce ghrelin, but it's dependent on the patient. Every patient's different. A patient could go anywhere from 6 to 12 months without feeling necessarily a sensation of hunger before those cells begin to regenerate. During that honeymoon phase, the 6 to 12 month period, we do work with the patient. We encourage you to get engaged in the aftercare program and work very closely with your surgeon, with your dietitian, attend support groups, because this period of time, this is the greatest window of opportunity for the most weight loss to occur, between 6 to 12 months. So we really need our patients to be very engaged and dedicated specifically during this window of opportunity, because that's when you're going to lose the most of your weight. Now, patients can continue to lose weight up to 18, even 24 months after surgery, but the majority of the weight loss is going to come within that first 6 to 12 months. So that's really when we need to work on those lifestyle changes, so that when the hunger hormone begins to come back and you do feel hunger, you know what to do with it. Okay? So that's the sleeve gastrectomy. One thing to note here is that by reducing the size of the stomach, the patient is then limited in the amount of gastric acid that can be produced because the surface area has been reduced. And because of that, specifically with a vitamin called iron, the patient could develop an iron deficiency. So even though we don't necessarily consider the sleeve gastrectomy as a malabsorptive procedure, Patients can develop vitamin deficiency, so it's very, very important to always take vitamins after surgery. Iron, I would say, is the number one that we worry about specifically with our female sleeve patients because of their menstrual cycle and things like that, and their ability to not absorb iron as well. So what this means is the patient will have to take more iron than they would with the normal anatomy because they'll need more to be able to absorb with the reduced gastric acid. I'm going to pause here just for a minute and just remind you again that there is a section to the right of your screen where you can type in any questions that you have regarding the sleeve gastrectomy. Here's a video for you.
It's a restrictive procedure that limits food intake by cutting and stapling a thin vertical section of the stomach to make a smaller, narrower stomach pouch. The remaining larger portion of the stomach is then permanently removed. Unlike gastric bypass, there is no rerouting of the intestines. However, the sleeve gastrectomy involves permanently removing a large portion of the stomach.
So a couple things that I would like to address that it said there on the video. First of all, I like this video because it's not showing you an actual surgery, so it doesn't gross people out. It's more animated, so that's why I choose to use it, but it is an older video. So a couple of things that it said on there, it flashed up there, it's not reversible. That's very true. That section of the stomach that is removed cannot be put in. I've had patients joke with me at their 1 week appointment and say, can you tape it back? Can you give me back my stomach? No. Once it's removed, it is a permanent procedure. We've permanently reduced the size of the stomach. But the other thing that it flashed up there is no long-term studies in the US. Well, that's because this is a very old video. The sleeve gastrectomy has actually been around for 15 to 20 years, depending on where in the world you talk about. The sleeve gastrectomy was actually started in Europe, not in the United States. So we do have statistical longitudinal data, but we're looking at 15 to 20 years worth of data as compared to the gastric bypass that has been around now for 30 to 35 years. Let me go back here to benefits and risks of the sleeve gastrectomy. Some things to know is that there is no rerouting of the intestines. It's a very straightforward procedure. So that is a benefit of the sleeve gastrectomy. We just reduce the size of the stomach. It does reduce the production of ghrelin, so it does decrease the hunger hormone. Again, that's a limited period of time. It does limit the amount of food that can be eaten at a time. That's true. Something to note here is that gastric bypass or sleeve gastrectomy are not quick fixes. They're not like taking a miracle pill, and they are certainly not the easy way out. When our patients come to us for weight loss surgery, they've tried just about everything to get their obesity under control. So, going through with weight loss surgery is certainly not the easy way out. Obesity is a chronic relapsing disease, and that's exactly how we treat it. That's why here in our program, we treat obesity with a multidisciplinary approach, meaning it's not just your surgeon who does the surgery and then you get sent down the road. Here in our program, we have bariatric nurses, dietitians, surgeons, medical weight loss doctors, and we also have a full-time therapist embedded in our program. So we help our patients through support groups, cooking classes, exercise classes, therapy. There's a lot of different things, a lot of different approaches that we approach weight loss surgery with. But one thing I want to make very clear is that the way that these surgeries work is through mealtime. You notice that it says limits the amount of food that can be eaten at a meal. So what that means is that when the patient eats a meal, they are to eat a high protein, low carb, it doesn't say no, it says low carb meal, so that when their pouch gets full, that protein is what makes that patient feel the sensation of fullness. So they feel fuller off of smaller portions. Now, they are not to eat snacks in between meals. They eat a meal, they wait until their next meal, and they drink liquid, their fluid. That's how they stay hydrated between meals. And then they eat their next meal, and so on. No snacking between meals is the number one thing that we have to have our patients be compliant with. If a patient were to go back to old habits of what we call grazing or snacking, eating little bits of food throughout the day and in between meals, then they're going to add calories to their diet, and they will either slow their weight loss or they will completely regain their weight. So I have many people that attend this class and they'll say, well, I knew so-and-so and they had weight loss surgery and they regained every bit of weight. They did not use the tool correctly. Okay. The patient has to understand how this tool works and they have to use it appropriately. So our patients gain weight loss by eating high protein meals, not snacking between meals. I say this because specifically with the sleeve gastrectomy, the patient could drink milkshakes all day long and it would pass right through their little stomach pouch. They would not feel a sensation of fullness. They would take in many, many calories and they would not lose weight with a sleeve gastrectomy. But the patient who uses this tool specifically at mealtime with high protein meals and no snack in between is going to knock this procedure out of the park and have excellent results long term. Average weight loss that a patient may see with a sleeve gastrectomy. Now, one thing I want to note, because we are a center of excellence, all of the statistics that I pull come from our national group called the ASMBS. So if you were to go to asmbs.org and you look up facts, you will find the statistics that I have listed here. I share this with you because some people will Google or go to blogs or vlogs or personal opinions, and I want you to know the facts. So I'm not only going to provide you with the facts about weight loss surgery and the average weight loss, but I'm also going to talk to you in a little bit about the death rate, and I'm going to talk to you about the specific other conditions and the percent chances of you getting rid of those. So I want you to know the facts, not opinions. Average excess weight loss, because we are a center of excellence, this means that I'm not just going to give you the average weight loss here in our program, but thousands and thousands of patients in the United States who've had the sleeve gastrectomy. Now, remember, when we talk about an average, just like a classroom full of students, you're going to have some students that put no effort in whatsoever and they fail the test. You may have some students that knock it out of the park and really adhere to those lifestyle changes. And then we've got a portion of people in the middle that may do a little bit of both, and they may have an average result. So the average excess weight loss with a sleeve gastrectomy is 50 to 66%. If we put that into pounds, with somebody who needs to lose approximately 100 pounds, they very easily could lose 50 to 60 pounds with a sleeve gastrectomy. Having said that, in my experience, someone who needs to lose 100 pounds, I have easily seen them lose 80 pounds with a sleeve gastrectomy and be very successful if they stuck to the rules and the lifestyle after weight loss surgery. The risks after surgery with a sleeve gastrectomy, again, it's not reversible. Can't put that stomach back together after it's removed. There is a higher incidence of postoperative nausea and spasms after surgery. And that's true because the incision line is very long down the side of that stomach. So the stomach is a muscle, and even though it is surgically induced, after having surgery, it feels like it is an injury to that stomach. So when muscles get injured, they spasm, they tense up, they cramp. And we have medication called Levsin that we put under the patient's tongue. It dissolves in their mouth, and it's a smooth muscle relaxant. So most patients, if they are going to have spasms, have them in the first few days after surgery, but we're able to treat them and keep them comfortable with that anti-spasm medication. Same thing with nausea. We have an entire protocol around nausea here in our program where we help to prevent nausea to begin with. But if the patient still has it, we have things like aromatherapy and medications that the nausea can be treated with so that they're able to drink and stay hydrated very well. Patients are less likely to suffer with, trying to read this backwards, less likely to suffer with dumping syndrome when eating something like carbohydrates or fats. I'm going to talk specifically about dumping syndrome here in a minute when we talk about the gastric bypass. But basically, in a nutshell, a patient with a sleeve gastrectomy can typically eat just about anything without having any negative effects from that. So that is listed as a benefit of the sleeve gastrectomy. Patients are likely to have an increase in acid reflux if they were to have the sleeve gastrectomy. So let's talk about that for just a moment. If you have acid reflux or heartburn and you take a medication every day to keep your acid reflux under control, this may not be the best procedure for you. So just be aware of that. The reason behind that is because the valve, the pylorus at the bottom of the outlet of the stomach, when it closes, because that stomach is now decreased in size and more like a tube or a sleeve of a shirt, okay, it's that tubular shape, it can cause a high pressure chamber, increasing acid reflux. So if you have it occasionally and maybe taken over the counter, it may not be a big deal. So talk to the surgeon about that. But if you take a medication every day, chances are this procedure may make your acid reflux worse. So this may not be the best procedure compared to the gastric bypass that actually treats acid reflux. Ulcers. All of our patients are at risk for developing gastric ulcers after surgery. So we have some rules around that. To decrease the risk after surgery of ulcers, we do recommend that our patients do not smoke, they do not drink alcohol regularly, and we also ask that our patients avoid two types of medications, one being steroids and the other being NSAIDs or non-steroidal medications like Advil, Motrin, Goodies powders. In bariatrics, we call Goodies powders ulcer packets because it greatly increases the risk of ulcers developing. So we do want to stay away from those type of medications. Okay, so one question's popped up. Could you stay on reflux medication permanently? Yes, you could. We have many patients that do stay on medications permanently. If we do have somebody who develops reflux after the sleeve and maybe they've never had it before, it is something that you can stay on. You may want to talk to the surgeon just about which type of medication that you're treating it with. But this is definitely a question to talk about with the surgeons. But yes, definitely you can stay on something permanently. I think the other thing I did not hit on yet here is staple line leak. I'm trying to read this backwards, so sorry. Staple line leak. I did speak about that earlier, about the 3 layers of protection that we give, and that's true with the sleeve gastrectomy and the gastric bypass. So there is a risk for a leak. We very closely monitor our patients in the hospital and after they go home after a sleeve gastrectomy or a gastric bypass. Now that's everything I had on the sleeve gastrectomy, so please feel free to add more questions here to the right of your screen. If you have any questions more about the sleeve, I'm going to move on now to the gastric bypass. Now that we have a good understanding of the normal anatomy, I'm going to explain to you how the gastric bypass is performed. So in this picture, what we see is that the patient has their esophagus that comes down. The surgeon has actually disconnected the top portion here of the stomach and brought it up. So he has sealed off the leftover stomach, created a pouch here out of the top portion of the stomach, and he's actually disconnected the small intestines and brought one section of the small intestine up and attached it to the base of the pouch here. So when a patient eats, drinks, takes medication after the gastric bypass, it goes in the esophagus, into the pouch, it gets dumped into the small intestine, the second part of the small intestine called the jejunum, and then it goes further downstream. Now note what the surgeon has done is he's actually sealed off the leftover, what we call the remnant stomach, and it stays in the body. It still has nerve endings. It still has blood flow. So this is actually still a live stomach, and the small intestine, the first portion, is actually reconnected further downstream because that stomach is going to continue to produce gastric acid, and downstream it's going to aid further in digestion. Now with this Roux-en-Y or gastric bypass, and you may see kind of the Y here formed, or here rather, after surgery, that's how it got its name. In this procedure, it means that the patient is going to have restriction, meaning that they're going to feel fuller off of smaller portions because their stomach is reduced in size. Therefore, they're going to feel fuller off of smaller portions and feel content. The other way that our patients lose weight with a gastric bypass is this is considered a malabsorptive procedure, meaning that the patient's not going to absorb everything that they eat or drink or even some medications. And so the patient with a gastric bypass is going to lose more weight than a sleeve gastrectomy patient normally on average because they do have malabsorption. Just like with a sleeve gastrectomy, a gastric bypass patient is at risk for developing vitamin deficiencies after surgery. Some of these deficiencies that could develop could be permanent, and one of those things could be permanent nerve damage. So we do have to make sure that our patients are safe and taking vitamins forever, every day for the rest of your life. Our goal is to get rid of those chronic health conditions and get you off of medications and instead put you on vitamins that are going to keep you healthy and safe for the rest of your life. Here's a video.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer nutrients and calories being absorbed. It reduces food intake by cutting and stapling the stomach to make a small stomach pouch. The small intestine is cut and the lower section is directly attached to the new pouch. Food then passes directly into the lower portion of the small intestine, bypassing most of the stomach and upper intestines.
Okay, so in a nutshell, the stomach is smaller and the intestines are rerouted so that you don't absorb everything with the gastric bypass. Now, benefits of the gastric bypass here. One thing is that you have a smaller stomach pouch. That's true. It's actually smaller than a sleeve gastrectomy pouch, which means, again, that you would feel fuller off of smaller portions. Now, listen carefully when I make this next statement. There is an increased intolerance of carbohydrates, sugars, and fats. So I'm telling you a benefit, which should be a positive statement, but I'm telling you that there's an intolerance, which is a negative statement. So I want to explain this a little bit. If someone with normal anatomy were to eat something that was high in sugar, fats, things like that, it would go down their esophagus. Let me move this up just a little bit. I have to stand. I talk with my hands. It's going to go in the esophagus, into the stomach, into the first part of the small intestine. It's going to be diluted. And then it gets into the second part of the small intestine. It's going to go on downstream as normal. A patient with a gastric bypass, if they were to eat something very high in sugar, fats, things like that, it would go down their esophagus, into their small pouch, and it would get dumped into the second part of the small intestine, which is called the jejunum. And remember, I said the word dumped. It's going to go straight into the second part of their small intestine. It's not going to get diluted like it was in the normal anatomy. And that section of the small intestine is simply not used to that concentration of food. And so what the body will do is it will actually pull fluid from the outside to the inside. The patient will experience some intestinal swelling, abdominal cramps, and they're going to run to the restroom and they're going to be sick, either nausea, vomiting, diarrhea, for about 45 minutes after that. That is called dumping syndrome. Now, I share this in the benefits category because if someone struggles with eating those types of foods, this can give them a sense of control. I say that because once someone experiences dumping syndrome, they don't feel good, they don't like it, and they begin sometimes to develop what we call an aversion to that type of food. Now, I don't want to scare you by saying this, and I do want to put in here that the majority of patients have what we call a threshold. So, for example, I had a patient that told me, she said, Amy, before I could not control myself, ate an entire, a package of Oreos before surgery. She said, after surgery, I tried that. Dumping syndrome, couldn't do it. She said, now I have a threshold. What I've learned is I can eat one or two, and I'm okay with that. But once I go over that threshold, if I eat that third one, I'm in the bathroom and I'm sick as a dog, and I just can't. My body won't allow me to do that anymore. And so in that respect, we do list that as a benefit because remember, we're in this for your health. We're in this to gain weight loss. And so that is a benefit of the gastric bypass. Okay, it does it limits the number of calories that the patient can absorb. Therefore, the patient is going to gain more weight loss than they would otherwise. Now, this is the best statement in the whole presentation, so listen up. I don't want you to miss this. After the gastric bypass, it produces positive metabolic changes immediately after surgery. So I have patients that have type 2 diabetes or who struggle with high blood pressure, some of which leave the hospital on no medications at all. Some of them leave on a half dose until they're able to get off the medication. This is because when the gastric bypass is performed and the intestines are rerouted, there are hormonal changes at the cellular level that occur that immediately show positive impact on high blood pressure and diabetes numbers. So immediately after surgery, before a significant amount of weight loss, we can already begin to see a difference in those numbers, and that's tremendous. Now, some patients leave the hospital on no medications. Some patients leave the hospital on reduced medication, or able, as they gain more weight loss, to wean off and get off of those medications. That's our goal for our patients. It is, now this procedure is reversible. That's listed as a benefit. Some people want to know, if I have problems, could the surgery be reversed? It can be reversed, although I will say that it is a very complicated procedure. It is not something that we should go into weight loss surgery thinking, hey, if this just doesn't work out for me, I can just always get it reversed. The number of patients that get their surgeries reversed are extremely rare. I can tell you, in the last 10 years, I've only had one patient that ended up having their gastric bypass reversed, and it was a patient that came to us out of state. This patient developed a psychological disorder and actually became anorexic and bulimic. And because the patient had already malabsorption from the gastric bypass, it actually benefited that particular patient to have their stomach, their intestines reconnected so that she would absorb more nutrients. So very, very rare, but it is reversible. Statistically, our patients who have the gastric bypass achieve more weight loss than someone who does not have the gastric bypass compared to the sleeve gastrectomy. And there is certainly a higher resolution of type 2 diabetes with the gastric bypass. That's why this procedure is considered the gold standard treatment for type 2 diabetes and for acid reflux, because by rerouting the intestines and getting rid of that pyloric valve at the base of the stomach, it treats and cures reflux. The average weight loss, remember, this is an average, national average out of thousands and thousands of patients, so it's the median results. Average weight loss is about 60 to 80% of excess weight loss. In the patient that needs to lose about 100 pounds, that equals about 60 to 80 pounds. Now, remember, we also treat patients that are higher than needing to lose 100 pounds. So we treat patients that need to lose 60, 80 pounds, but we also treat patients that maybe need to lose 300 pounds. So this is a percentage, okay? A percentage, and it's going to give you a pretty accurate estimation. But for somebody who needs to just lose 100 pounds, that's a pretty good average. However, having said that, it's the national average, and in my period of time, I have seen patients that have achieved 110, sometimes even 120 excess weight loss, depending on how consistent they have been with their food choices, portion sizes, and certainly not snacking between meals. Risks after having a gastric bypass. There is a risk of nutritional deficiencies because of the malabsorption. So again, our patients have to take vitamins for the rest of their life to maintain normal vitamin levels. Now, it is true that some patients, maybe only 2 to 5% of patients, may develop a pouch outlet anastomosis. I'm reading backwards, so I apologize. Pouch outlet. Yes, okay, I was thinking the same thing, I just wasn't wording it the same way. Pouch anastomosis, basically the outlet of the stomach that is now hand sewn with the bariatric surgeon after surgery. If the patient were to overeat consistently and put pressure on that outlet could begin to stretch over time. And if that happened, again, only 2 to 5% of the case, then the patient would not feel full. They would feel hungry all the time. And the surgeon would have to go in and do a revisional procedure, meaning that they would have to go in and they would actually have to hand sew that outlet smaller. Now, Carney Wilson is a celebrity who's been very open about her weight loss journey, and she did have a outlet stretching, and she ended up having to have a revisional surgery to regain weight loss. All of our patients, regardless of sleeve gastrectomy or a gastric bypass, are at risk for developing gastric ulcers. So again, same rules apply with the gastric bypass. We do avoid smoking, alcohol, steroids, and NSAID medications. A leak we've already discussed in great detail with the sleeve gastrectomy. The same is true. We use staples, suture, and tisiel to decrease the risk of a leak forming. A couple of other things that are specific to a gastric bypass is about 5% of patients may develop what we call a stricture after surgery. That means that hand-sewn area that he connects at the base of the stomach to the second part of the small intestine, it could potentially scar down and actually heal too tightly and become too narrow. And the surgeon may have to go in this area with a balloon and actually dilate it and open it up. So that would, if it were to happen, it typically occurs within 4 to 6 weeks after surgery. But again, it's a very simple fix with a balloon dilatation through endoscopy. The only other thing on this list I think that we haven't spoken about already is an internal hernia. So this is more of a long-term risk with the gastric bypass. It only occurs in about 5% of patients. But what that means is as the procedure is performed, the surgeon actually has to, there's actually a layer of tissue across the abdomen called the mesentery. Connective tissue, it is made of some fat content as well. So as our patients lose weight on the outside, they also lose weight on the inside, and this he has to actually poke a purposeful hole in this area to bring the intestines up. As the patient loses weight on the inside, this purposeful hole could actually grow larger, and that means that the intestines could potentially get trapped and get kinked in that area. So unlikely to happen, only happens in about 5% of cases, but when it does, it is an easy fix. The patient would just need to go back, the surgeon would go back in, and he would hand sew that area to a smaller window to prevent it from happening again. All right, that's the gastric bypass in great detail. I talked about the anatomy, the way that it's performed. I talked about the benefits and risks. So over the right-hand side of your screen, please feel free to ask any questions that you may have about the gastric bypass, and I'm happy to answer those before we conclude today. I'm going to talk briefly about contraindications to surgery. If somebody is an active smoker, this is not the time to have an intervention and to start a healthy lifestyle. We've got to start first by quitting smoking. Our surgeons will not perform surgery on a patient who's actively smoking because nicotine, whether it's nicotine, it's e-cigarettes, it's nicotine gum, nicotine patches, marijuana even, it produces a situation in the body where it causes vasoconstriction, meaning that the vessels actually tighten down and decrease blood flow to the stomach specifically, which greatly increases the risk of a leak, which can be a bad complication. So our surgeons will not perform surgery on somebody who is an active smoker. So the first step is to stop smoking. So if this is a situation for you, please reach out to us and we will help you with some options there. If someone is breastfeeding or pregnant right now, it's not the time to have weight loss surgery, although it's a good time to start thinking about it. So for our patients who are already pregnant or they're thinking of becoming pregnant, our surgeons typically require the person to be about 12 months after having a baby. However, my recommendation is to get started 6 months after having the baby because it can take 3 to 6 months, depending on your insurance requirements, to actually get to surgery. Okay, that's a great question. So we've got a question about medications for depression. So you'll notice that one of the contraindications I have listed here is current treatment. Let me see. I'm reading backwards. Oh, untreated psychiatric illness. So one of the things that is very important to understand is that we've performed very successfully surgery on patients who have depression, anxiety, bipolar disorder, schizophrenia. The trick here is that they have to be treated and they have to be managed very well. So if somebody's managed very well on medication, then they're in a good position to go through a lifestyle change and have great success. But if somebody has a depression disorder and they're not well treated and they're really struggling with depression, they're not going to be able to focus on making these lifestyle changes and maximize their success. So we need to get the depression under control with medication, counseling, that sort of thing, so that they can really maximize their success. Let me read this question one more time, make sure I answered it. So no trouble in taking medication after surgery. You can actually swallow pills the same day as having surgery, so no issue there. One thing to consider about any medication, whether it is for depression or any other issue, is the type of medication that you're on. More specifically, if you consider you're having the gastric bypass, because the body simply may not absorb it as well after surgery. And so for patients who maybe are on medications that are instant release or timed released medications, things like that, then you may consider switching to a different type of different type of pill. Or for example, some people may go on, like if somebody has to have a non-steroidal medication for joint pain, then you may go from a pill to a gel like Voltaren that you can rub on the joint, or a patch. So we may consider different routes of medication so to make sure that you get it. Regarding vitamins. Okay, great question. So do vitamins come in a pill form? Can they be taken in a combination of foods, liquids, pills, chewables? Yes. Vitamins for bariatrics come in pill form. They come in chewable form. They come in crystals that you can mix in water and drink like a flavored drink. They also come in patches. And believe it or not, some medications, specifically B12, actually comes in a nasal spray. So lots of different forms and ways to get your vitamins in. So lots of different tricks for sure. If somebody has an active drug or alcohol issue, this may not be the best time to have weight loss surgery. So we do want to get those issues under control, but simply so that you can focus on a healthy lifestyle. If somebody, one other thing to point out is about alcohol in general. We do ask that our patients avoid alcohol specifically for 12 months after surgery. If you remember a statement that I made earlier in the session, I spoke about the maximum weight loss being in that window between 6 to 12 months. So what is alcohol made of? Alcohol is made of sugar. So it's going to work against weight loss. And it's going to prevent you from losing weight. So we definitely want to abstain from alcohol for at least 12 months after surgery. But then after that, we do need to make sure that our patients are aware that our patients will actually absorb alcohol in a very different way after surgery. So our patients can actually have a heightened effect very quickly after drinking, and then it will go away very quickly. So something to be very aware of is the first time you experience alcohol after having weight loss surgery, you need to be somewhere safe with someone that you trust, and you don't need to be behind the wheel of a car, because whatever that limit is, 0.08, legally, whatever's considered a DUI, doesn't matter who you are or what type of surgery you've had. If you've met that limit, you will get charged with a DUI. So it's something that you need to make sure that you stay away from. Never, ever drink after weight loss surgery, and drive or even anytime, right? But specifically after weight loss surgery, because people think that they're going to be able to tolerate the same amount of alcohol, and they simply cannot. So just be very aware of that. If somebody is undergoing current treatment for cancer or chemotherapy, this is not the time to have weight loss surgery. However, if you remember what I said at the beginning, there are some cancers that are linked to obesity. So we certainly do perform surgery on patients who've had cancer because we want to keep them from having any other type of cancer. So it depends on the oncologist. When the patient is in remission and they feel that they're in a healthy state, then they can move forward with having weight loss surgery. If someone is unwilling to make any diet or behavior changes after weight loss surgery, then this may not be the thing for you. Our patients need to enter this and go into it with an open mind because we need to make some lifestyle changes, whether it's food choices, portion sizes, that sort of thing. That's one reason specifically why we have a cooking class here in our program for our patients. We have it in person and on videos. Here on this YouTube channel, you're welcome to go to our videos tab, and you can check that out so that you can learn other cooking methods and other recipes. So we just ask that you have an open mind, you try different types of foods, and you begin practicing not snacking between meals, because that's the number one rule that you're going to need to follow after surgery. Which surgery is recommended for someone with end-stage renal disease? Either one of these procedures are great, but it does depend on what the renal disease or kidney disease is related to. So that's an excellent question. I've actually had patients that were on the transplant list for kidneys or for liver. And yes, we do perform weight loss surgery or metabolic surgery on these types of patients, because if we can get their weight and their chronic health conditions down, then they can either get on a donor list or perhaps reverse the damage that's been done in some cases and make the function of the kidneys or the liver better afterwards. So it doesn't, both procedures would be helpful, but one thing to consider is that some kidney disease is related to diabetes. And if that's the case, type 2 diabetes, The gold standard treatment for that would be the gastric bypass. So just something to keep in mind. That might be the better procedure, but it does depend on your history, your medical history. Okay, I'm reading about smoking. Okay, so someone's just commenting about stopping smoking and the struggle with that. Some patients do feel an increased sensation of hunger after they stop smoking because nicotine sometimes can curb appetites. And so that is something that we definitely need to work on. One thing I would highly recommend is if you're already in our program, you're one of our patients. And so I want to make sure that you know that we do have a therapist here in our program. His name is Aaron. And that is somebody that I would want you to, let me see if I have one of his business cards here so I don't see one, but one thing that you could do is give Aaron a call. Our number here, I've already put up there in the link. It's 770-219-0446. You love Aaron. Good. So he is a great resource because he specializes in addiction, whether it is smoking, alcohol, food, and he may be able to give you some great tips on that. So I would highly recommend getting with him and working with a dietitian to work on that piece for sure. So let's talk about some statistics in regards to results that you can look forward to after surgery. And remember, my data comes from asmbs.org, so it's national data out of thousands of patients. When we look at high blood pressure and hyperlipidemia or high cholesterol, on average, patients can look forward to about 79% of patients going into remission or getting rid of their high blood pressure or high cholesterol after surgery. The reason that number is not higher or closer to 100% is because both of these diseases have a genetic link. So we can't change your family history, but what we can do is help you to get your obesity under control and either make the disease go away, and if not, reduce the medications that you take. I've had some patients in my past that were perhaps on maybe 5 different types of blood pressure medication, for example, after surgery, and they were able to go down to just one if they weren't able to make it go away completely. And that's a huge, tremendous benefit. Type 2 diabetes, 86% of patients saw an improvement nationally, and about 78% of patients saw a remission rate or their type 2 diabetes completely go away. That's the national statistic. Here in our program, we're closer to 85% of type 2 diabetes going away. So back to that renal disease, if we're able to get the diabetes under control, if the renal disease is linked to diabetes, then a lot of times we have a very, very good chance of getting the diabetes to go into remission, and then likewise getting that kidney function to get back to the best that it's been in many years. It depends on how long somebody's had renal issues. If it's end stage, then our goal would be to get you out of the end stage and reduce the stage that you're in and increase that kidney function and try to avoid dialysis if we can. Obstructive sleep apnea, about 86% of our patients, if they struggle with sleep apnea and are having to wear a CPAP or BiPAP machine, then they can hopefully get rid of that about 86% of the time and not have to count on wearing that anymore. Preoperative evaluation, one thing that I do recommend is that if you are considering weight loss surgery, I do recommend that you consider going ahead and moving forward with a consultation with a bariatric surgeon. Just because you see a surgeon does not necessarily mean that you are having surgery tomorrow. What it means is that you're going to an appointment with a specialist to look at your specific situation so that he can give his specialist opinion on your condition, your results, your type of surgery that would be best for you. So I highly recommend taking that next step. I look at the consult with a surgeon as an information gathering session. So that's why I recommend that. Some things to know is that they're going to take a very thorough history, medical history, surgical history on you so that they can specifically answer to your specific situation. They're going to ask about your medications for that very reason, whether it's depression or other issues. They want to know what types of medications, what routes, and that sort of thing, so they can make recommendations there. They may ask you also about food triggers for you and your eating patterns so that they understand where they're starting from and what we need to work towards with your lifestyle changes to maximize success with the procedure. If you have a specialist already in your life, if you see a cardiologist, an endocrinologist, a pulmonologist, you may be asked to have another appointment with them prior to your surgery to get a letter stating that your doctor has put you in the best condition possible. So, for example, a kidney doctor, a nephrologist, that would be a great example. If you don't have kidney issues, you don't have to have that appointment. But if you do have kidney issues and you're already working with a specialist, your bariatric surgeon wants them very intimately involved in your case to make sure that we have maximized your kidney function or your lung function or whatever it may be, your diabetes. We want that condition under the best, tightest control that it can be in so that we can safely get you through surgery. So those doctors would work as a team very closely to safely get you through surgery. Now, if you don't have any of those specialists, the two minimum appointments that you would be needing is a psychological evaluation with a psychologist. Now, the reason that we do that is, number one, is a national standard of care for bariatrics, because we know that as our patients go through that psychological evaluation, we are making sure that you are in the best condition that you can be in mentally and emotionally for surgery. But that psychologist may also pick up on some things. So if you have anxiety and it's not controlled, or maybe you have a family history that maybe needs to be addressed and talked about before surgery or after surgery, they're going to make a recommendation for you. They may say this patient's an excellent candidate for weight loss surgery and we have no recommendations. Or they may potentially come back and say, we need to get this patient's anxiety under control so that they can better focus on the lifestyle changes, or they may recommend working on a couple of sessions on how to better control the impulses to eat now that you've quit smoking, whatever that may be. Our goal is to set you up for success, and we are here to partner with you to do that. So that's what that psychological evaluation is for. We do require a primary care letter, and the reason behind that is because we do want to make sure that you have someone that is working with you to take care of your medical conditions, your medical needs. And we also want to make sure that whomever that doctor is, that they are supportive of your choice to have weight loss surgery. We never, ever want someone in a position to where they go to the doctor and they feel berated or judged on having weight loss surgery. So we want to make sure that your physician is supportive of that, so that when you go back to your primary care for a physical, for a urinary tract infection, for the flu, we want to make sure that you have a good, safe place to go get medical care. If you do not have a primary care physician, I would like you to let me know that. Either you can let me just email us or give us a call, and we do have a recommendation for a couple of our primary cares locally that are very supportive of our patients having weight loss surgery. Some physicians, unfortunately, are still biased against obesity, and they are biased against weight loss surgery simply because they're ignorant and they don't know the statistics and the safety of the surgery. And I don't mean that in a negative way. I'm just making a statement based on my experience. And so just know that they may not be supportive because of those reasons. One thing that we're doing here in our program is myself and our surgeons are actually going around and speaking to not only primary care physicians, but OBGYNs, orthopedic surgeons, kidney doctors, heart doctors, pulmonologists, to educate them, because weight loss surgery has drastically changed over the last 35 years, and the outcomes are drastically different and better. And so I want them to be aware as well. What to expect, the length of surgery, the average is about an hour and a half long. The surgery stay, it depends. Some of our patients may be a great candidate for outpatient surgery and go home a few hours after surgery. Other patients may be a candidate for staying overnight. And as I said before, typically our average patient will go home the next day at noon. They do need to be able to drink, they need to be able to walk, they need to be able to urinate on their own, and their pain and nausea need to be controlled so that they can go home and go home safely. All of our procedures are done laparoscopically, which means they're done through small incisions, similar to how a gallbladder is done. Because of the laparoscopic approach, our surgeries, our patients are able to recover very quickly from surgery. We do have a weight restriction of only lifting 5 to 10 pounds for the first 2 weeks, so that we make sure that you do not pull anything. Most people can realistically go back to work in 2 weeks after you've learned to eat and drink again, and you're going to be confident you're not going to vomit in the middle of a meeting or something. So about 2 weeks is very average. If somebody has a heavy lifting job that they're not able to get accommodations for, then you may be looking around 4 to 6 weeks to return to work. So just be aware of that. Our surgeons, a couple of them also use the Da Vinci robot. It is a laparoscopic approach, but we do use the Da Vinci robot made by Intuitive, which means that that robot has an arm that articulates in a way that the human arm does not. And so there is an advantage to that just for precision. Okay, possible complications. We've already addressed these things through discussing the sleeve gastrectomy and the gastric bypass, but I want to make a point here with this list. If you were to undergo any, even a minor procedure, you would be at risk for blood clots, pneumonia, wound infections, bleeding, and death. It is on every single surgical consent that you would ever sign. The risks that are complication risks that are very specific to gastric bypass or sleeve gastrectomy is the intestinal leak, which we've already discussed, ulcer formation if a patient didn't stay away from NSAID, steroids, smoking, and alcohol, stricture, only 5% of patients, nutritional deficiencies if someone did not take their vitamins every day. Now, the only thing here that our patients are at an increased risk for is DVT or PE, which is a blood clot that could go to the lung or the legs, which is why we have a very strict protocol in our program, and we go over that with our patients to prevent blood clots. It's the number one reason our patients get up, usually around an hour and a half or at least within 6 hours of surgery, because it circulates the blood in the legs. Death rate with bariatric surgery, I point this out because it's the elephant in the room. After patients leave this, they may have a conversation with friends, family members, coworkers, telling them that they're considering bariatric surgery. And their reaction may be something like, isn't that too drastic? Do you weigh enough to have weight loss surgery? Couldn't you die? Isn't it risky? Isn't it dangerous? I want you to be armed with the facts. I've already gone over the statistics for the majority of health conditions that are related to obesity and the significance benefit that you can get from that. But one thing I want to point out is, number one, not the easy way out, because you still have to work for this. There's a lot of lifestyle changes that are necessary to be successful. But when we're talking about the death rate, if you look here, a gallbladder, if someone were to have their gallbladder out, the death rate is 0.7. That's good. It's less than 1%. The death rate with a hip surgery, 0.93. Again, it's good. It's low. But look at the significantly lowered death rate with bariatric surgery. It is 0.13, significantly lower than even having your gallbladder out. And yet we can help to get 40 to 60 other health conditions. And we can shorten a person's premature risk of death by 30 to 40%. Adding about, on average, 7 to 9 years to someone's lifespan. So I wanted you to be armed with that information. Again, asmbs.org is the place that you can find these statistics very easily. Now, how are you going to be successful after weight loss surgery? You're going to eat a high protein diet. You're going to drink your liquids between. You're going to try to strive for protein between 80 to 60 grams. You're going to drink 64 ounces at least of fluid a day. And I don't care for the word exercise. There's a negative connotation, but you need to find some form of physical activity that you don't mind. Doesn't matter if it's dancing, it's walking, it's hiking. You need to find something that you're interested in that does not feel like you have to do it. Something that's fun. Okay, in our program, we have a lot of free resources to help our patients make these lifestyle changes. In our program, we don't just do the surgery, we support you every step of the way. We have dietitian counseling. It's totally free for our patients that do weight loss surgery. We have cooking classes virtually and in person. We have bariatric yoga, bariatric weightlifting, both in person and live through our YouTube account. We have a clothing closet where you can shop out of gently used clothes, support groups. We do have a big following on our closed YouTube group, our closed Facebook group and YouTube, so that you can find some virtual support as well. Just like we're teaching this class, we live stream our support groups as well. So if you live a long distance away, you have a work schedule that doesn't allow for you to do things at certain times, you can always go back to our videos and check those out. This is our Berry Boutique, where our patients can shop out of gently used clothes. We carry size 6X down to a small. So we help our patients find clothing that is free so that you can keep yourself clothed as you go through rapid weight loss. We have a recipe wall based on our recipes that we do on our cooking shows or cooking classes as well. So my dietitian is actually in an appointment today. I'm going to skip some of her content because I've already talked about it, but there is this slide that I would like to show you. This is what a meal might look like before surgery. So you see that 50% of that plate is filled with low calorie vegetables, so carbs. 25% is filled with a starch, which is also a carb like bread. Only 25% of this plate is filled with protein. So what we're simply going to do after surgery is we're going to switch up that, and we're actually going to change it to 50% protein, and we're going to decrease the vegetables and the starch and things like that. So that you're eating more protein than you would have before. It's going to fill your pouch full of protein to make you feel fuller faster, and you're going to be able to do very well with surgery. So this is just talking about the vitamin and mineral requirements. So multivitamin, calcium, B12. No need to worry about this now. You just need to know that you need to take vitamins for the rest of your life. And so that's the end of what I have. Except for the surgeon video. So I want you to enjoy watching these and get to see each one of our surgeons so that you can know who you might be interested in seeing after surgery.
I grew up wanting to be a primary care doctor like my dad, and realized when I got to medical school that I really liked operating. So I get to have the best of both worlds in a lot of ways. I get to do general surgery, very refined, very specific type of general surgery, but I also get that long-term care and follow-up with the patients that I was looking for when I was growing up. But we get to experience as bariatric surgeons, patients seeing diabetes go into remission, or blood pressure being controlled without medicines. We get to go walk Disney World for the first time, from the front entrance to the back with their grandkids or kids. That's really cool. And you don't get that experience with a lot of other types of medicine. So I love it. Northeast Georgia Medical Center is a great place to have surgery. One, we do meet the national guidelines for Center of Excellence. We've consistently done that for a very long time. The nurses are incredible. The anesthesia staff, the people that make this possible, do a great job. It's not just the surgeon being safe, all the parts of the puzzle falling into place, falling well. What I would tell a patient who's considering bariatric surgery is to learn. Learn as much as you can. Talk to friends, talk to family, go on the internet and talk to some virtual people. But at some point, sit down with a surgeon you feel comfortable having a relationship with, and really do a deep dive on your own personal history. Do a deep dive on what your goals and aspirations are. The surgery itself is not a finish line, it's a starting line. The starting line for the treatment of a chronic disease, which implies chronic ongoing care. So if you feel comfortable with that physician, with that surgeon, that you can see them for the rest of your life, that's the first step, I think, to having a successful surgical event.
Well, bariatric surgery can be a great option for someone who is.
I'm going to clarify. This is actually Dr. Richards, so just ignore what it says up here, okay?
And we're going to be successful. A lot of these patients have tried other things to lose weight, and they're skeptical because they've tried it. They might have lost the weight and they've regained it, and they want to know why this is different. Well, this is different because we're going to provide them with a tool that will allow them to continue with this weight loss journey long term. We're going to teach them how to use the tool, and we're going to follow. Our discipline of bariatric surgery is a discipline that we can prevent so many diseases by treating this one condition, obesity. And then treating that one condition, we can prevent that renal failure from the diabetes, because we can send diabetes into remission. So this is a very powerful discipline. We build long-term relationships with our patients. You know, the follow-up is key to long-term success with bariatric surgery. I finished my training in 1998, and I spent 4 years in the Army doing trauma, as well as doing bariatric surgery. I did start a program at Fort Campbell before joining practice here in Gainesville. So I've been here since 2002, and I currently practice 99% of what I do is bariatric surgery. I do very little with anything else. So this is what I do. I guess the best part about being a bariatric surgeon is just knowing that you have a powerful tool, knowing that when that patient shows up in your office on oxygen with a walker or a wheelchair, knowing where that person's going to be 6 months later, knowing that you can get that person off that oxygen, and get that person out of that wheelchair. That's the fun part of my job.
All right, hang on. I got one more surgeon video. Let me just see what happened here. Bear with me. I've got one more surgeon video.
My name is Alex Wynn. I'm a bariatric general surgeon. Been practicing in the Northeast Georgia area since 2000.
Well, let me see what I can do here. Something's not working right. Oh, goodness. Okay, well, I don't know what happened there, but I do have one more surgeon. His name is Alex Wynn, and he is part of our NGPG program. So with that being said, if you guys have any questions, I'll be happy to answer that. And then I'd like to refer you back to the top of your screen where I have questions and where I have an email address for you, danielle.jackson@nghs.com. And also our phone number at 770-219-0446. So if you're ready to get started, whether it's with a nutritionist, the medical weight loss, intragastric balloon, or surgeries, just let us know how you would like to move forward and we can get you set up. Any questions that you guys may have? All right, you're welcome to send questions there as well to that email address and we'll get those answered for you. Hope you guys have a good day. I hope that you got some information out of this and take care.